So like Marla said, my name is Chris Peterson. I'm a general dentist. I practice up in West De Pere. And first of all, I'm honored to be here. I have known Marla, like she said, over the last couple of years, and we always have fun when she comes in. And thank you so much for organizing this whole thing. It's been really cool. It's been really cool to get out of dental mode for a guy like me. I always am in dental mode, and it's nice to see things from other disciplines, when it comes to sleep. So it's been a great group of speakers. There's obviously a wealth of knowledge in this room, and I don't know about you, but I'm soaking it in like a sponge. So it's been great. It's really good to be talking to a room of like-minded people, like I said, who are obviously here because we know how important sleep is to our patients and their overall quality of life. And this conference is a great medium for that, to have open dialogue and figure out how we can all help. So one thing I've learned since being in the tongue tie world is that it's really a big time team approach to this whole thing. We got to involve each other. So that's one of the reasons I selfishly I kept begging Marla to let me talk for the last couple of years, is so I could actually meet some other providers. And I've already had some really good conversations, so it's already been worth it for me. So hopefully you guys get something out of this. We're going to talk about tongue ties and how it relates to sleep apnea. So let's do it. First of all, no conflicts of interest for me. And I am going to talk a little bit about me. I don't love doing that, but we're going to start here. That's back in the glory days, back at St. Norbert. I played 4 years of college basketball at St. Norbert, up in De Pere, which is right down the road from where I practice currently. I met the love of my life at St. Norbert, and she's actually just popped in the back row. I see her back there. So we got married right after undergrad, and then we got to go to Pittsburgh for dental school. So I called it a 4-year honeymoon. She thinks of it a little differently. But it was a great 4 years, and then I wanted a little bit more training before I jumped into private practice, and I did a 1-year residency. It was 6 months in Milwaukee here at the VA hospital, and then 6 months in the Green Bay VA clinic that was brand new at the time. Learned a lot, took a ton of teeth out on veterans, and it was great. So kind of launched me into private practice and doing general dentistry. So then I arrived at De Pere Smiles, and I worked for another dentist for a year, and then bought the practice, and it's been about, I think, over 5 years now that I've owned the place. And we've been growing a lot, and the newest thing that we're currently working on is renovating an existing building. So the tongue tie stuff has really just blown up over the last few years, and so we're actually going to have a dental clinic on one side of the building and a tongue tie clinic on the other side of the building, with some lactation support that we're going to start offering, and speech therapy, myofunctional therapy, stuff like that. Lots of cool things ahead. So that's what we're working on right now. Another thing you got to know about me is that I like to have some fun and joke around, and I got this book as a gift from my staff for Christmas, and I think it was their hint that I need some new material because I keep saying the same thing over and over again. So I got some jokes in here. So I know it's the last one of the day, and just want to keep it light. So yeah, good, perfect. So why tongue ties? I get the question a lot, like, why did I get into this whole thing? And I'm going to blame it on my wife, like I do everything else. But these are my 3 kids and my beautiful wife, and my oldest daughter's 6 right now, but when she was an infant, she was breastfeeding, and it wasn't going perfectly, and we laid her down to sleep, and she just cried in pain, and we're like, is this normal? We don't know. My wife was like, my mom gut is telling me something's wrong. So we had a lactation consultant come out to the house, and she mentioned that Audrey might have a tongue tie. And I, first of all, I'm like, I'm a dentist. The mouth is my wheelhouse. I should know about that, right? I didn't have any training in tongue ties in dental school, 0 in residency. So it got me thinking. So we fast forward a little bit, and we got a procedure, a lingual frenectomy completed for Audrey after like a 4-week wait, because there's a huge need for that in the area, and that's the next step for me, is that we got trained on how to do that. But we had some improvement for Audrey, and like I said, I got some training under my belt. I went out to Boston, learned under Marty Kaplan how to do infant frenectomies, and then went down to Arizona to get certified to use a CO2 laser. Then went out to Portland, learned a little bit from Bobby Gahary, and started treating babies in our office. Pretty much exclusively infant frenectomies, and it's grown to children and adults now. So it's been pretty cool. So what do I want you guys to get out of this course today? Whenever I go to, or this presentation, whenever I go to a course, I always admire when the information is just going to help me make concrete steps to implement something in my practice like immediately. So I wanted to make it practical. And by that I mean maybe you're a provider who's always suspicious of ankylosing but not sure how to diagnose it or even screen for it. Or maybe you're pretty sure that your patient is tongue-tied and you're like, how do I treat this? Do we do therapy? Do we do a tongue-tie release? How do we move forward? So I built this presentation to help you feel more confident in your abilities to help your patients. And first off, we have to know where things originate in order to understand how to prevent them. So we're going to talk a little bit about infant tongue-tie diagnosis and treatment and how that is the best prevention moving forward. Then we're going to go to children and adults, and I want to turn your suspicion into certainty and teach you how to diagnose and screen properly. And then treatment options for children and adults. So the past few years, I watched the presentations from last year, and talking with Dr. Taché, who wasn't able to be here today, he wanted to put a little bit more emphasis this time around on children and adults instead of infants, because there were some really good talks on infant ankylosing. But we're going to talk about how to quickly and effectively screen your patients for ankylosing, what to do with them, because we've seen it so many times in our practice where the infants or the parents of infants, they present so differently. The people that come in, the patients themselves are diagnosed with the tongue tie, and it affects them all so differently. The treatment options are so drastic, and the patients don't know which way to turn. So my hope is that this presentation helps you to start understand the next steps for your patients and how we can together help to create treatment avenues for your patients. So I'm going to put a heavy emphasis on oral myofunctional therapy. I know we touched on that earlier. Dr. Villarreal was talking about that earlier. So I'm going to go into that a little bit more in depth. And there's great evidence to support that this is the best route to start for some patients. So it's just some housekeeping stuff here. This is from the International Affiliation of Tongue-Tie Professionals. I talk about it every single day with patients, but a frenum or a frenulum is just a strand of tissue that connects the tongue basically to the floor of the mouth. Super easy. You can see it right up there. Ankylosing, and this is where there's a little bit of confusion because patients will come in and say, yeah, my provider told me that tongue ties don't cause problems. And we say, okay, well, frenums, we all have that, but we're going to try to figure out if it is a functional issue or not. And that's when we decide to call things a tongue tie or ankylosing. Does that frenum restrict normal movement and cause functional issues? So that's what we're trying to weed through. Like I said, I just want to touch on the topic of infants here, and then we're going to get to adults. But it's important to see how, if caught and treated properly early, lots of negative consequences can definitely be avoided. So I send emails out with videos all the time to local medical providers. They probably get sick of hearing from me, but I'm always trying to focus on teaching how to screen. Okay, because if you get a mom that comes in that looks like that and asks you point blank, hey, does my baby have a tongue tie? Is that why they're gassy and fussy and why it hurts for me to feed them? And you don't really know what to say. Hopefully I can help you out a little bit. But I always send those videos out, and I got a YouTube page, Peterson Smiles, so I got the link up there for a video that's a little bit more in depth about how to screen for infant tongue ties, so check that out. Pretty good stuff. So let's dive into infants here. Screening, super simple. Two things. Questions to ask, you gotta ask the right questions, and do a proper exam. And it's a total bonus if you have a feeding assessment. If you have a lactation consultant that does a feeding assessment, and there's a lot of objective tools to use, like a Hazel-Baker assessment. I'm sure you've heard of that. But either an assessment from a lactation consultant or a speech therapist or some other feeding specialist. And we're lucky enough to have an IBCLC on staff. I promised her I wouldn't embarrass her, but she is sitting right over there. So thanks for coming today, Acacia. But this helps us get a complete picture of the infant's function to help us decide whether or not to recommend a release. So yeah, if you have a feeding assessment available, use it by all means. But let's start with the questions. So which questions to ask? So you guys can find all this information on our website, by the way, but at depersmiles.com. But this is the questionnaire that we give to all parents of infants who schedule an evaluation, and it runs through the infant's symptoms and the mother's symptoms here. If the mom is breastfeeding. It's derived from Dr. Richard Baxter, who wrote that book that's pictured up there, Tongue-Tied. It's a great resource. I highly recommend it. So yeah, we always go over this form with parents and explain how a tongue tie can lead to these types of problems. Then we perform what's called a knee-to-knee exam. I learned that from Dr. Larry Kotlow. He's a pediatric dentist out in Albany, New York, and he's been doing tongue tie stuff, I think, longer than anybody, probably 40 plus years. But I tell providers that all you need to do an exam properly is a pair of gloves. If you got a headlight, great, but all you really need is a pair of gloves. So it's important to get into position like a dentist, and don't worry, even if you're not a dentist, this is your chance to act like one. So looking from overhead, really important. So lay the baby in your lap, pull the upper lip and tongue toward yourself, because if you're looking at a baby without doing the overhead assessment, pushing things is so much harder than pulling things. You can get a better feel of the tissue when you're just pulling things toward yourself. So you can get a really good idea of what the frenum looks like and how restrictive the frenums potentially are. The next thing is the feeding assessment, the infant exam form. So we always complete an infant exam form, which is also derived from Dr. Richard Baxter. I stole a lot of things from him, and he's okay with it. We try to objectify everything that we can and record the findings that we have for the infants coming in. The next thing would be the feeding assessment. So we have that lactation consultant on staff to perform the feeding assessment, and this is how I explain proper breastfeeding mechanics to parents. It's all about forming a vacuum-like pressure. We know that now. And that vacuum-like pressure is going to help drain milk from either the breast or the bottle. And in order for any vacuum to work, we need to form and maintain suction first. So if we have clicking noises during feeding, if there's milk leaking out of the baby's mouth, if the baby just latches and delatches a lot, they're breaking suction all the time, and we're going to have major problems. So the key movements for the tongue are forward, or protrusion we call it, and upward movement or elevation, in order for that suction to be formed and maintained. So I'm going to expand on the elevation of the tongue a little bit later and why it's so important, but not just for breastfeeding, but for proper growth and development of the facial structures. We always say that breastfeeding with a proper deep latch, by the way, is nature's orthodontics. It helps form the palate appropriately, and bottles and pacifiers just don't do that. So this is a study, an ultrasound imaging study where it just showed that babies use that tongue in an upward, downward movement to create that vacuum-like pressure. I put on here a case study of an infant that we saw not too long ago. It was a 2-week-old infant that came in for a lot of issues, but she was breastfeeding, and the mom reported that there was a shallow latch. It was painful when she nursed. There was clicking noises during feeding the entire time. There was excess spit up after feeding. Baby was colicky and hiccuped after every feeding. During the exam that we did, the infant had nursing blisters on the lips, like chapped lips, a milk tongue or a white coating on the tongue, a high roof of the mouth, and it was pretty narrow, and then a hypersensitive gag reflex. So we ended up performing a release. That's what the parent decided that they wanted us to do. So we used our laser to release that tongue, and that's immediately after the procedure. And it was kind of amazing. They came back at the 1-week follow-up, which we do for every infant. And there was resolution in almost every symptom that the infant had in 1 week. It's kind of crazy. So that's why we keep doing this, because it's a lot of fun, helping those young families. Because I've lived it. It's not fun being there with a colicky baby and all that stuff. So I'm going to show you a video here. I think it'll work. This is a frenectomy. We use a Solea laser, it's called. It's a type of CO2 laser, and it's really great for soft tissue. We can vaporize. It's technically called ablating tissue, but I tell parents we vaporize tissue without causing any bleeding. If we can really see where we're going so we can get a full release. So I'm hoping this works here. So we use that groove director, it's called, to elevate the infant's tongue, and we got Acacia is the one now that, or my lactation consultant, holds the baby nice and steady, so it's a safe procedure. We don't sedate at all. And then you just use that CO2 laser, and you can see that tissue just opening up really nicely without any bleeding. And pretty much the aim is to get to the genioglossus muscles so that they are free of restriction. The excess tissue in front of them, or that frenum, is what we're trying to eliminate so that the muscles are just not restricted anymore. So that's that. Painful? It doesn't feel good. Absolutely. I always tell parents I could lie to you and tell you that this baby's not going to feel pain, but that's lying. So I've lasered my fingers before on accident when we're working, and it doesn't feel good. So we use topical anesthetic that's safe for babies, topical lidocaine, tetracaine mix. But yeah, I mean, it's a couple seconds. You know, we always tell parents, look, a couple seconds of pain is probably a little bit healthier for the baby than sedating them. So we work it. I was actually trained by Marty Kaplan out east to not use any topical anesthetic at all. And I started doing that, and then I got questioned on that and did some more learning, and we used that topical anesthetic. So, all right, I'm going to transition to children and adults, and I told you I have no reason why that's up there. I just think it's funny. So let's go to children and adults. So child and adult ankylosing. So in 2012, there was an amazing study, a cohort study by Karen Bonnick that was pretty eye-opening, and it changed how we looked at how sleep-disordered breathing can so negatively affect not only the growth and development of a child and their face, but how it can negatively affect children neurologically. So snoring, sleep apnea, mouth breathing, they contribute to that ADHD, behavior problems, and increased aggression and anxiety. Piggybacking off of that, in the same year, 2012, the American Academy of Pediatrics offered these new guidelines for children who snore. Basically, they should all be screened by their primary medical provider, and if snoring is reported, a sleep study should be performed, or the patient should be referred to a sleep specialist or an ENT for possible adenotonsillectomy to open up the airway. Another crazy fact is that 60% of a child's facial development is completed by age 6 and 90% by age 12. So getting in there early, prevention is definitely the best thing to do. Now, we know we want to encourage proper growth and development and tongue position, and there are a lot of removable appliances. I put some pictures up here. Myo Munchie is one of them that I just ordered for my kids. I don't know much about it, but I want to try it. Yeah, I chatted recently with a local orthodontist, and I just kind of brought it up, and I said, what do you think about these removable appliances in kids? And he said, you know, sure, they can work, but compliance issues, potentially with removable appliances and in kids, you know, I know we can all relate to that. It's just tough to enforce that. So he said, you know, I don't put anything in the child's mouth unless it's a fixed appliance, and I believe that has the best chance of working, but it's tough to get, and we're going to talk about palatal expansion a little bit in a couple slides, but you can't really do that until around age 5 or 6, you know, when those adult teeth come in generally. So, yeah, but I just wanted to mention that there are things out there like this that might have a benefit for sure. So let's talk about diagnosis here. We hear it every day at our office. My doctor told me that I can stick my tongue out and I'm not tongue-tied. Well, my answer is always the same. The tongue is meant to do a lot more than just stick out your mouth. It's meant to elevate, move laterally, swallow. I mean, there's a lot of different movements, and probably the forward movement is one of the least important. But I want to point out that I can relate to the training that these providers had. Didn't have a whole lot in my residency or in my dental school. So I know their training is minimal at best, but we can do better than saying, oh, stick out your tongue. You're not tongue-tied. So let's talk about how to diagnose it. In 2016, Dr. Audrey Yoon and Dr. Sarush Zagi of the Breathe Institute, they introduced an objective way to screen for functional ankylosing. So this is what we use every day in our office when we have patients come in, and it's just a little ruler. You can get it from Great Lakes Orthodontics, or I'm sure there's other companies that make it. But it pretty much measures the anterior tongue mobility. So you can have the patient open as wide as they can, first of all, and measure that. So you get a measurement, X, and then you have them put the tip of their tongue right behind their front teeth, and you guys can do it right now if you want, but put your tip of your tongue behind your front teeth and open as big as you can while keeping it there, right? So then you get a percentage of how open you can be when you do that versus the first measurement, your maximum incisal opening, we call it. So that percentage puts you on, they have 4 grades, so it puts you on a gradient there. So grade 1 would be like very little tongue limitation. Grade 2 is, I forget the percentages, it looks like 50 to 80% of that maximum incisal opening is grade 2. Grade 3 is about is less than 50%, and then less than 25% is a grade 4, so severely restricted. So then, 5 years later, we realized that, hey, the tip of the tongue moving upward is not only not the most important movement. What about the back of the tongue? Can we get it to elevate? So another screening tool was introduced by Dr. Zaghi, and it's because we know how important that back of that tongue elevating is for so many reasons. But it's called lingual palatal suction. So the body of the tongue contacts the palate, and it suctions to the roof of the mouth. Here's a picture of it. So it's the same type of thing. You have the first measurement of maximum incisal opening, and then you have the patient suction their tongue to the top of their mouth and open as big as you can while doing that. And then you take that measurement, and it's kind of crazy. A lot of people just can't open more than 2 or 3 millimeters. It's nuts. That would be severely restricted. So that puts you on a grade, you get graded 1, 2, 3, 4. So we use these 2 measurements. I can't see this here. The tongue tip and the lingual palatal suction is part of our screening process for every patient that comes in. So that kind of objectifies things a little bit for us, other than just the clinical exam and looking at things and the appearance and the tightness of the tissue. But similar to our infant tongue-tie questionnaire, we have a child and adult tongue-tie questionnaire, and it's also from Dr. Baxter. But we use that in our practice, and it goes over more things than just can you move your tip of your tongue upwards? But it goes over the main issues of eating solid food, speech, and sleeping, and then a history of nursing issues. So it gives us a more complete picture of what's going on. And here's some other clues for you. Napoleon Dynamite up there. You guys probably know who that is, but mouth breathing, that's a classic mouth breathing presentation. Forward head posture, people lean forward to open up the pharynx, and it decreases airway resistance. And then the tonsils that look like that. If we see those and they're snoring in children, we know what to do. We want to refer to an ENT for possible adenotonsillectomy. So this is another screening tool. This one's from the International Affiliation of Oral Facial Myology, and they recommend this screening tool for a dental office in particular, but I'm sure it can be used in other offices. So there's a lot of good screening tools like this, I'm sure, out there, but it just helps clarify whether or not there's an airway problem or an oral facial myofunctional disorder, or OMD, we're going to call it. So let's get into those a little bit. So an OMD, as described by the IAOM, is an atypical adaptive pattern that emerges in the absence of normalized patterns within the oral facial complex. The regular presence of these adaptive patterns movements can also result in a variety of disturbances. Another definition by the AOMT, which is another organization, it talks about how that may affect breastfeeding, facial skeletal growth, development, chewing, swallowing, speech, occlusion, TMJs, tons of stuff. So examples of OMDs would be anything from thumb sucking, finger sucking, tongue thrust during swallowing, abnormal swallowing pattern, mouth breathing. And how do these relate to sleep? If we have bad habits while awake, we probably have bad habits when we sleep. So, I know we hear the term sleep disordered breathing a lot, and it can be better described as breathing problems that lead to sleeping problems. So if we're doing stuff when we're awake, we're probably doing them when we sleep. So I just want to point out there's a lot of really good organizations out there and resources for us to understand OMDs and how to treat them effectively. It's kind of a problem. There's not like an overarching organization that is in charge of the certification for that. So, we work with an oral facial myofunctional therapist. I'm just going to call her an OMT. But she was talking about this the other day. She just, there's no certification for her, but there is from other groups. So it's like, who do you send to? So hopefully in the next couple of years or in the future, we're going to have more clarification on this, and we know what kind of therapist to send our patients to. All right, quick brain break for a minute. Patient told me that one last week. I thought that was funny. Okay, so how does tongue tie relate to the OMDs? In 2017, there was a study completed with 229 patients who were suspected to have sleep apnea. Their oral anatomy was evaluated, and it was determined that in patients with a restricted lingual frenum, they had clear impairments of both their maxilla and their mandible, including a high and narrow palate. So obviously there's a tie, no pun intended, between restricted lingual frena and the anatomy of the upper airway that favors collapse during sleep, obviously putting our patients at risk of OSA. There's another study that was completed in 2017 by Dr. Yoon and Dr. Zagi again. 302 patients. They looked at their oral anatomy, and their conclusion was that tongue tie, or when the tongue is tied to the floor of the mouth, it leads to low tongue posture, which can lead to underdevelopment of the maxilla without that tongue resting on the roof of the mouth like it's supposed to and putting pressure up there. And the key thing here is that the soft palatal tissue is elongated instead of widened transversely. Okay, and therefore it's higher propensity to sag into the airway, causing obstruction. So the development of the palate is huge. Basically, if the tongue's restricted, it leads to low tongue resting posture potentially, and mouth breathing, since the nasal airflow is restricted because the nasal cavity hasn't formed properly, because the palate hasn't formed properly. It's a problem. So I got a video on the next slide here. Talks about mouth breathing. It's a cool video that the therapist that we work with told me to watch, and I show it to patients once in a while. It's really good for explaining the negative effects of mouth breathing. So let's see if it works.
The normal or physiological way of breathing is through your nose. Breathing through the nose permits to purify the air by the structures inside the nasal cavity. In that way, the air entering into your naso and oropharynx, your throat, is not going to heavily affect the lymphoid tissue in the adenoids and tonsils, which is the last barrier to catch harmful particles in the air before it reaches your lungs. Besides clearing the air from harmful particles, nasal breathing stimulates the production of gases and substances in the nose, which are going to facilitate the entrance of the air in the lungs and prevent infection in your respiratory system. Mouth breathing allows the air to pass directly into your throat, where the adenoids and tonsils are located. In that way, the air entering into your body through your mouth has not previously been purified, and the lymphoid tissue in the adenoids and tonsils become the first defensive barrier against the harmful particles contained in the air. As a consequence, that lymphoid tissue overgrows, occupying a large volume of your throat. That makes more difficult for the nasal breathing, and you make a habit of breathing through your mouth. In order to breathe through your mouth, your lower jaw has to come down, as well as your tongue has to rest on the floor of your mouth. Breathing through the nose is the correct way, and so the tongue is able to rest on your palate, stimulating a normal growth and development of your upper jaw. Conversely, when you breathe through your mouth, your tongue has to descend and protrude. At the same time, the pressure of your cheeks increases, pushing the upper jaw inwards. So the growth and development of your upper jaw is negatively affected, resulting in a narrow and high palate. The upper dental arch acquires a V shape instead of being a rounded dental arch. Therefore, your teeth do not have space to properly align. This also produces an incorrect swallowing function. Every time you swallow, between 1,600 to 2,400 times per day, the tongue positions low, staying away from your palate. That forces the tip of your tongue to position between your upper and lower front teeth. That pushes your front teeth to show out of your mouth, and your tongue resting on the floor of your mouth, with the tip of the tongue between your front teeth. That is called an open bite, as your upper and lower front teeth do not touch when you close your mouth. All those dysfunctions, mouth breathing, incorrect tongue posture, open mouth, and incorrect swallowing, are going to continue affecting the growth and development of your upper and lower jaws. And as a consequence, there is less room for your teeth and they become crooked. Remember, the nose is for breathing and the mouth is for eating. Breathing through your nose and keeping your mouth closed with your lips together is going to help your upper and lower jaws to grow and develop better. But more importantly, it makes you healthier.
Remember that. The nose is for breathing, people. Mouth is for eating or smiling at the Pierce Smiles, right? Okay. So that was a pretty good video. I wanted you guys to see that. And you just YouTube mouth breathing, and it's right there, so you can show your patients that too. Okay, so Let's see. Now that I pointed out a bunch of problems, let's talk about some solutions. Dr. Richard Baxter from Alabama, Tongue Tie Center, he is big on the 3 opportunities that we have. He always says, keep it simple. We got 3 things that we want to look at, 3 things that we could fix. So let's talk about them. First off, tonsils. If they're in the way, refer to an ENT, get them out of there, especially in kids. We're learning that today. Talked about it a lot. Second, if the palate shape is affected, let's fix it, and we're going to talk about that in a second. And lastly, if there's a tongue tie that's restricted, let's free it up so we can perform the way we want it to perform. And then we got to train it to do what we want it to do. It's not just going to magically do that, so we'll talk about that in a minute. We talked about this a little bit, rapid palatal expansion. So if you have undiagnosed ankylosing into childhood, instead of getting it fixed in infancy, the palate shape has likely been affected, and now we got to expand the palate. So orthodontic work is a great non-surgical intervention. Like I said, you got to wait roughly till age 6, so we have that conversation with parents a lot. And then we can get patients into the orthodontist and get things expanded. So I don't know, how many of you guys have had this in your life? Anybody in here? Yeah, cool. A couple of them. The nice thing here is that it widens the nasal cavity floor as it widens the palate, and it creates less resistance to nasal airflow. So this is a cool one. In 2017, there was a systematic review. I believe we already talked about it today. Rapid palatal expansion, it helps decrease the AHI in young ones, even after adenotonsillectomy and then recurrent or unresolved sleep apnea. So that was pretty cool. So what about adults? When you get to adulthood and you got a messed up palate, are you just screwed? Is it too late? Call it a day? Or can we fix it? So it's not quite like putting a square peg in a round hole, but it's not as easy as kids. Let me go back to that. Yeah, so now that we know that the mid-palatal suture has been fused around the teenage years, and ask a bunch of orthodontists, they'll tell you different ages. If you want to get orthodontists in a fight, you ask them if they can expand a palate on like a 17-year-old. They'll be like, no, or yes. So just like I did before, there's a lot of removable appliances for adults as well that claim to expand the maxilla, and it puts you at risk of compliance issues. Same thing. Adults are a little bit better than kids usually, but it's not a fixed retainer, and the orthodontist that I talked to that we work with a lot, he just believes that it doesn't really change the maxilla as much. It changes the flaring of the teeth. It pushes teeth out, which doesn't do exactly what we want it to do. But it does give you more room for your tongue. So like I said, I don't know a whole lot about them. ALF appliance is one of them. The Homeo Block and the Vivos DNA are pictured up there. So, so let's talk a little bit about surgery. Surgical interventions for adults. The palate, like I said, the mid-palatal suture is fused. So what do we do about that if we want to fix it? So distraction, osteogenesis, we actually talked about a little bit earlier, but this is for the maxilla instead of the mandible. And pretty much an oral surgeon does what's called the Lafort-1 osteotomy. They take the maxilla off of the skull, and then they can manipulate that mid-palatal suture a little bit. They take mini implants, they place them on the roof of the mouth, they put an expander in there just like for kids, and they expand the palate. So it can be done. The benefits to this would be pulling the soft tissue transversely to keep it out of the airway so it doesn't sag, widening the nasal floor to create more space for the nose breathing, and then creating space for the tongue to rest on the roof of the mouth. So here's a study, 2018 on DOME, I'm just going to call it. 75 patients with a narrow maxilla went through this treatment, and in the end, DOME was successful at alleviating nasal obstruction, and the AHI was decreased and the amount of REM sleep was increased. So it worked. Another follow-up study just showing that pretty much the bigger the floor of the nasal cavity, the less collapsible the airway or the pharynx. And a secondary benefit, like I said, is that we're going to create room for that tongue to rest on the roof of the mouth. Now, like I said before, now we got room on the palate. If there's a tongue tie, let's release it. But is it magically going to go where we want it to go during sleep and suction to the roof of the mouth and stay out of our airway? Usually not, okay, especially in adults. The hope in infants is that they'll just provide or have good habits moving forward at that point, but adults and children, it's hard to do that without intervention, so we need some therapy on board. So let's talk about Orofacial myofunctional therapy, or OMT. It's therapy used to correct the improper function of the tongue, lips, jaws, soft palate, larynx. And funny story, I'm actually in the middle of my OMT right now because I'm a mouth breather probably half the time. And now I learn all about these bad things, and I'm like, well, I better do something about it. So I'm probably 6 out of 12 sessions in, and it's been kind of cool. I get to make some really funny noises at home, lip smacking and stuff like that. And like Dr. Villarreal said earlier, Google OMT and you'll find some cool exercises. So let's talk about the 4 main goals of OMT. First off, nasal breathing. We talked about that, super important. So training yourself to do these things during the day will hopefully help us do them at night. There was a good study done in 2003 on only 12 patients, but it was pretty cool. They measured the upper airway resistance in nasal breathing, nasal breathers and mouth breathers, and it turns out that resistance was much higher in the mouth breather category than the nasal breathers. So, like I said, once I found that out, I signed up for OMT right away. The second goal is lip seal, and once my wife found out that I was going to get trained to keep my mouth shut, she was all on board. So, but seriously, there's really good reason for keeping the lips sealed instead of keeping the lips open. You think even if you're breathing through the nose, if your lips are open, what's the big deal? Well, there's a really cool study done in 2011 where intraoral pressure was measured by some really smart people. They figured out how to do that, I don't know, but they had 20 patients. They had them seal their lips and have an open mouth, and they measured the pressure in their mouth. And there was actually a lot of negative pressure generated from that lip seal, which helped the tongue suction to the roof of the mouth, like we want it to. So the third and fourth big thing with OMT are correct tongue posture and correct swallowing pattern. So I'm going to show you a case. An interesting one. So tongue movement, you can see that bottom picture there where the tip of the tongue is elevating, and it's not a whole lot of restriction there. So there was no tongue tie, what we would call, but there's still, you can see the V-shaped arch like we saw in that video, and the bottom teeth are flared out because that patient, when they swallowed, their tongue thrusted into their teeth and it put force on them, and then we get that flaring of the front teeth. All right, I'm going to admit this is actually me. So I have a tongue thrust, and I'm working on getting that fixed. And I was never referred to orthodontics as a child, and I probably could have used some palatal expansion and maybe some OMT. But that's what our goal is to diagnose our patients and get them the help they need. And the help is out there, so we just have to find it. All right, if we have time, I don't know, how are we doing on time? Cool. So I was just going to say, what I want you guys to do real quick is just close your mouth and swallow. Does your tongue touch your teeth? It's not supposed to. It's supposed to just press firmly into your palate. So I bet you there's some of you out there where your tongue touched your teeth. That's called a tongue thrust. And then without orthodontic help, your teeth would look like mine. And all you Office fans out there would probably think this is funny. But if you don't watch it, not so funny.
Supposed to?
What's that?
Is it supposed to touch your teeth?
No. Tongue is supposed to press into the palate firmly when you swallow.
Okay.
Yeah.
Thank you.
Yeah.
I needed to know.
Yeah. So let's see, what do we do about achieving these 4 goals in patients who are affected by OMDs? Like we said, OMT is the treatment, but if patients grade poorly on those screening protocols that we addressed earlier, the tongue tip to the roof of the mouth and then the suction, the lingual palatal suction, then a lingual frenectomy is probably going to be recommended in addition to OMT. So we work with a therapist in the Green Bay area, like I said. Then we perform a number of these procedures on patients where we like to do therapy to get the tongue ready for the frenectomy. Then we perform the frenectomy. And while we're doing it, the patient can actually suction their tongue to the roof of their mouth and open. They train them to do that for 2 minutes so I can take my time and do a nice procedure. And the muscles are where I want them to be so that when we release that, we're going to get all the excess tissue out of the way. So there's a really good study, the largest study with patients that went through OMT and did a frenectomy, Dr. Zaghi in 2019. And significant improvements were noted in mouth breathing, snoring, clenching, myofascial tension, 348 patients. So there's definitely success that can be had with those things. A couple really cool cases that we did recently. This was a father of an infant that came in. So we helped the infant, and we started talking about what we don't want to happen with growth and development in the future if we didn't do something. And he's thinking, oh my gosh, this is me. This is me. So we started talking about him. And I said, today's not about you, man. It's about the little one. So why don't you come back and we'll talk about it and fill out this form. And so he had this questionnaire filled out, and he reported mouth breathing during the day, during the night, slight speech issues. He said, I had a drink of alcohol and I started stuttering. He's like, that's not cool. And we hear that a lot. Neck and shoulder tension was another big one for him. So he went through, I believe, 12 sessions of OMT, and after the fourth one, we did a tongue tie release. And he had major improvement in every single area. It's crazy. He said he ran differently after that. So, the fascia that's connected to the tip of your tongue, it really goes all the way down to your toes. So it's pretty crazy. Another case, now this is another father of an infant, actually, came back, and he went through OMT for a couple sessions, and this is a picture before the tongue tie release was done. And you can see the difference. The muscles of the tongue are much more strengthened and much more defined, and that frenum is thinner on that picture on the far side there. So it's really important to get those muscles and everything ready for that release versus just saying, hey, let me just laser this and send you on your way. So I tried so hard to get a video of an adult frenectomy over the last couple of weeks, but I just need a better camera. The phone just kept zooming in on the wrong thing, so we'll keep trying. But, I just want to say that OMT is a really good therapy. That is the treatment in my mind for this sort of thing. And a tongue tie release is just an adjunct to that, It's not the opposite way around. So if we don't have to do a tongue tie release, like in my case, we just do the therapy, and hopefully that facilitates the ideal outcomes. This is a 7-year-old that we did, also went through OMT. The parental complaints were poor nursing as an infant, mouth breathing, neck tension, history of speech therapy, and she was a slow eater. And after completion of the OMT and a frenectomy, she was totally nasal breathing after that. It's pretty cool. There was no neck tension. She ate faster. She pronounced more words immediately. Parents are always kind of happy when their kids can talk better. No, she just wouldn't stop talking after that, but it's pretty cool. So I get this question a lot, do you put sutures in or do you not? I was trained to not put sutures in, and obviously in infants we don't do that because we just can't get them to hold still long enough, and plus a suture coming out would be an aspiration risk. But there's about 6 months ago I started doing sutures on adult patients or even children when we could, and we could get them to stay still. On a 3-year-old it's a little tough, but there's the key advantages of primary intention wound healing. Leads to less scar tissue, and hopefully that leads to less restriction in the future, because if it heals up really, really tight, that's not good either. And the really good thing that the parents or the patients and the parents like the most is that they don't have to do therapy for the first 4 days after the procedure. So we say, let's stitch you up, let's approximate the wound where we want it to go so we can idealize the healing process. And you don't have to do anything for 4 days. And they're like, okay, that's good, because I used to do it the other way where they could not do the stretches that we recommended them doing afterwards because it hurt so bad and it was a big wound there. So stitches seems like the way to go. So this is a case that we did recently. It's when we did stitches, and it's the before picture and then 1 week after. You can hardly even tell that there was a wound there. It's crazy. I think she healed just super fast. And I said, I got to take a picture of this and share that. And I guarantee it wouldn't look like that if we went to put stitches in. Here's another case. This is actually my associate dentist. First time I did an exam on her when she had a cleaning, I was like, oh my gosh, your tongue. And she said, yeah, it was fixed when I was a kid, and I think it grew back. So we're actually doing, I call it couples therapy. We're doing therapy together every week, but we did a tongue tie release on her, and you can see the difference. The frenum almost seems like it's not there, and she can move her tongue, and she said for the first time in her life she can clean her back teeth with her tongue. So pretty cool. Let's see here. Okay, so this is from the same study that I was just referencing. There's a really important point here, and we need to make sure that our patients have adequate tongue space for a tongue release. And if they don't, a tongue release should not be performed. So let's talk about that. Here's a lateral CT of 2 different patients showing the airway space at rest. And you're going to notice that it also shows the tongue posture, the tongue resting posture. So the one patient has his tongue resting on the roof of his mouth, the other one does not. So which one do you think would be a better candidate for a tongue tie release in therapy? the one that does not already have his tongue on the roof of his mouth. So that would be the patient. Now, are we going to take a lateral CT on every patient? It's not really practical. So we look for other things during the clinical exam. Having the patient perform a lingual palatal suction will allow you to visualize if the tongue spills over the biting surfaces of the teeth, or the occlusal surfaces we call them, and therefore not enough room, like that patient right here on the right. They can elevate their tongue decently, and they're grade, it would probably be a grade 3 on that patient, but their tongue is just spilling over their occlusal surfaces of their teeth, so they need their palate widened. So that's where that surgery would come in if the patient wanted to talk about that. So what are the options for patients like this? We talked about the dome, obviously CPAP, if there's sleep apnea. Mandibular advancement device would be another one. But what else? Is there something that we're overlooking? What about OMT alone? So this is a study that was just referenced today. But there was a systematic review, 2015, just talking about OMT for sleep apnea, and how it really helped. Out of the 120 patients, 50% of the adults and 62% of the children had significant improvement in the AHI following OMT alone. So, at the end of the review, it talks about how it's a good adjunct therapy. We talked about doing 1% of everything, improving 1% of everything, and hopefully that just helps us overall. Yes, I was listening earlier today. But yeah, it's a good adjunct therapy, so it's something to really think about. Another review from 2021 talks about OMT for sleep apnea treatment. And like we talked about earlier, it's basically a workout for your muscles involved in your upper airway to strengthen them so that they don't collapse as much during sleep. It makes sense. So we should consider this for treatment for residual sleep disordered breathing after adenotonsillectomy, and also as an adjunct therapy in combination with like CPAP or a mandibular advancement device. All right, so I hope no one looks like that out there, but we made it to the end of the whole day. So just a quick summary, just remember prevention is always the best. If we can diagnose and treat a tongue tie in an infant, let's do it. And when we have children or adults with suspected airway issues, look at the big 3. The tonsils, if they're in the way, get them out of there. The palate, if you can idealize that, let's do it. And if there's a tongue tie, let's fix that. And lastly, OMT is a great treatment for oral facial myofunctional disorders, including sleep disordered breathing. That's it. Thank you.
Dr. Peterson.
Oh, yeah, go ahead.
So that can grow back?
Oh, yeah. Yeah, so after a tongue tie is released?
What's the percentage?
It's a good question. It's a tough thing to measure. We always do a 1-week follow-up for all our patients that we do frenectomies on for that reason, so we can show the parents, if it's an infant, the stretches again, because we do recommend stretches. Because otherwise the wound will heal back together. I always tell parents, if you don't do them, they will heal back together. It's not fun. I've gone through that 3 times as a parent, but we got to do that. And then the 1-week follow-up for the kids or the adults, you reinforce that and make sure the wound is not reapproximating. But yeah, sometimes they call it a staged procedure. I've heard that term before. I don't really love it because it makes it sound like the way around that, in my opinion, is do therapy if it's an adult or a child. Get the tongue ready instead of doing a tongue tie release first and then trying therapy, because then you're going to isolate that frenum a little bit more and it's going to come back, and it's going to seem like it comes back, and then we got to do it again. So that's why the therapy first is such a critical thing that we're really implementing with all our patients, and we're highly recommending that. Yeah.
Could I add one thing to that?
Yeah.
Just adding to that, most tongue tie releases that I do are in the NICU, like critically ill premature babies. They're really small, they're not able to do therapy and things, and those are kids that you might see had a tongue tie release, and then a little bit older following up would need to have it redone.
Well, my son had a tongue tie release like 27 years ago. So she asked him now if he has any symptoms. But it was a once and done.
Well, you could measure his lingual palatal suction and all that stuff, yeah.
Paula.
Do lip ties have the same thing for newborns? I mean, what are the, my granddaughter just had her lip and her tongue tie done. I get the tongue tie, but the lip tie,
Yeah, great question. So in infants with breastfeeding or bottle feeding, we want a deep latch, okay? So we can actually form that suction that we want to form so we can have that vacuum. work. And if that upper lip is restricted, we're going to see that upper lip not flange out over top of the breast during feeding, and it kind of tucks under, and it's just a smaller mouth for the baby, leading to that shallow latch, and it's kind of like biting on a straw and sucking through it, so it just doesn't work that well. So that depth of latch is super critical under that frenum in that upper lip area. We call it a lip tie, or the maxillary labial frenum is restricting that movement of that upper lip. Then we're going to have that not going to have that nice flange during feeding. So there's buccal ties too. There's buccal frenums up there on the sides that we look at a lot too, and if they're really restrictive, then we'll let parents make the decision on if we want to release that or not. But if that lip's not flanging, absolutely. Later in life, it's going to be pretty much, a little bit of growth and development of that upper jaw, that maxilla, and spacing between front teeth. Michael Strahan, I would love to see what his upper lip looks like, but that's what we're worried about, Yeah.
The time my grandson was tongue-tied, so at like 10 days old, he had that released. But they did say he also had the lip tied too, but it wasn't that. I don't know what stage that was. But they said they wanted to reevaluate him, like when he's like 4 or 5.
Sure. Yeah, really good research to support releasing a lip tie as soon as possible. Dr. Baxter just came out with a really good study that debunked the orthodontic thought process that, hey, we should wait till the orthodontics is done, close the space between the teeth, and then do the frenectomy because they're worried about scar tissue. He said, well, let's measure some stuff. Let's do the release early on, as early as we possibly can when the baby teeth are there. Let's measure the space and let's watch them close. And it closed. So we always say sooner rather than later. It's such a low risk, high reward thing, especially with a laser. You can see where you're going. No bleeding. It's super clean, pretty easy.
What would be some things to then look for, doing the release?
What do you mean look for? So like spacing between front teeth?
I
Or a
think she
reason
means
to...
what could she use as a reasoning for wanting it done when the doctor says it's not time?
Yeah, we hear lots of things about lip ties. Physicians will say, let the kid fall and they'll rip it. And we hear that every day. Like you gasp, but we hear it every single day. So it's like, well, let's control the procedure and have it be surgically perfected, instead of like partially tearing and blood's everywhere and the parents are freaking out and then they don't stretch it and it heals back together. So it's such a low risk, high reward thing to release that at an early age. If there's spacing between the front teeth, with baby teeth, you don't really care. You want spacing between the baby teeth. But if you can elevate that upper lip and you watch that tissue blanch right between the teeth, you know that it's going to be a problem with adult teeth. So, but if it's not, I'd watchful waiting.
I was just curious for adults, if they've had previous surgery like a TNA or a UPPP, how does that affect tongue tie?
That had previous surgery. That's an interesting question.
Because would that change how things are kind of shaped in the back?
Yes, and it would provide more room for the tongue to fall backwards, right? But it wouldn't change the anatomy of the frenum. So if the tongue can't elevate with those measurements we were talking about, then it's still not able to suction to the roof of the mouth. And that's what we want it to do, is suction to the roof of the mouth so it keeps it out of the airway. So I don't think that would affect the resting posture of the tongue, except for maybe a little bit more backward. Yeah?
So with the little babies.
Yep.
And I'm assuming like symptoms are more breastfeeding issues. Do you though have issues with babies that are breastfeeding, like babies that are bottle feeding? And then this two-part question, I'm assuming like the best exercise is for them to get back on, latch on, and breastfeed as much as possible to work that tongue right. Does bottle feeding, is that an issue?
Yeah, we see a ton of bottle feeding babies, and usually parents report that the symptoms, like the clicking noises or the milk leaking out of their mouth, is worse on bottle feeding. And we kind of give the analogy, it's kind of like going from a waterfall to a water fountain breastfeeding to a waterfall bottles, depending on the size of the opening, because you can compensate for a baby's lack of ability to form a suction by the bottle nipple shape. We see some crazy nipple shapes out there, like flattened. It's like, well, you don't want your nipple to look like that, mom. So if you're bottle feeding, don't give a baby a pacifier that's flattened, by the way. I'm not a fan of that. But yeah, definitely we see a ton of bottle feeders. And if they can't form that suction on the breast, they're not going to form it on the bottle a lot of times. And so we have it all the time where the doctors say, well, baby's gaining weight, don't fix anything. Okay, well, we know what can happen. So let's have the conversation about growth and development. If the tongue's locked on the floor of the mouth, I mean, we're going to see lots of problems. So it's not just for baby gaining weight, although yes, that is a primary thing that we want to watch out for.
And one from the Slido, could you comment on insurance coverage?
Yes, we have really good dental insurance coverage. Private dental insurance is what we accept. Medical insurance, we do submit every case that we do, a tongue tie or lip tie release, to medical insurance. Usually it's just to get the denial because dental insurance looks at it as primary. The medical insurance is primary, so we got to get the denial first and then submit it to dental insurance to get the reimbursement. But I mean, Delta Dental, we get reimbursed 100% a lot of times. So yeah, we know that information before the patient walks in the door. Usually we let them know it's going to be X amount out of your pocket today, and it's been working really well.
All right, thank you.
Thank you so
Awesome.
much. Ooh, lots of questions. Next questions on there.